workforce through problem-based learning of clinical reasoning, the AfroDiagnosis Initiative. Karibu sana David.
Thank you very much. Good evening, everyone. I know you've had a long day, and here is a refreshing session for you. So I have to start with one of our favorite stories. We've been told in the morning that physicians like to talk about their patients, and therefore I decided to start with a patient story. So this is a 27-year-old female who presented with a 3 weeks history of nausea and vomiting, and this was several times a day, and she did not have any abdominal pain, diarrhea, or constipation. But then on the day of presentation, the husband reports that she was responding to questions inappropriately, and she had loss of balance when walking, but there is no history of fever, head injury, difficulty in breathing, but she also reports double vision. And then on examination, you find she's confused. The left eye is deviated to the left, and she also has ataxia. And a few labs that have been given, the patient is having a high urine specific gravity, ketonuria, the glucose was normal, there is low magnesium, and then a high anion gap metabolic acidosis. So as introduced, my name is David, and together with my colleague, Dr. Joseph, we are going to present what we've been doing for the past 2 years. We believe that good quality medical care starts with an accurate diagnosis, and despite advancements in technology, basic diagnostic skills are still needed to make sure that we ensure cost effectiveness, we give right management to our patients, but we also ensure patient safety. And therefore it's very important to make sure that we strengthen how clinicians are trained, which made us ask ourselves this question, that how do some clinicians get so good at what they do? And we know this is not the case with everyone. Is it the generic advice that you should see more patients and maybe read more? We believe that is not the case, because many doctors are seeing a lot of patients, and they also read a lot, but they are victim to the twin assault of the forgetting curve. So you forget a lot of material as soon as you read it, and sometimes, as given in the case, you have read about something, but then coming to apply it in real life becomes a problem. And another big issue is that in our daily practice, especially for practicing physicians, the decision density is very huge, and sometimes we do not get time for feedback. And human nature is that if you do not get feedback, you just assume the patient that I saw got better, but maybe they didn't get better, maybe they died, or they went to another facility, maybe you made a wrong diagnosis. So what is the ideal solution? The field of cognitive psychology, especially K. Anders Ericsson, who is one of the most famous cognitive psychologists and summarized these findings in the book called Peak, talks about a concept of deliberate practice, which is basically you practicing or training at the margin of your ability, giving yourselves challenges which are not too easy to bore you and not too difficult to make you give up. Get constant feedback and then work on the feedback, but this should be based on real life problems, integration, and also fitting in your tight schedule, especially for us physicians who are very busy. So me and Joseph had been big fans of some online resources like the UCSF Medical Grand Rounds. There's a YouTube channel called Clinical Problem Solvers, but also reading the New England Journal of Medicine, their CPC cases and case records of the Massachusetts General Hospital. So after procrastinating for a number of months or years, we came with this idea of AfroDx. And our very first session, it was just the two of us. Joseph prepared a clinical unknown a case I was blinded to, and I discussed that case. So the way we do this is the presenter reveals bits of information which we call aliquot. So for example, they'll just start with patient particulars, and then the chief complaints, and then the discussant will share what they think of the case by thinking out loud. So we proceed that way until the end, and then we end with some teaching points and reflections. Over the past 2 years plus something, we've opened these sessions to the public. We started with our classmates when we were with whom we graduated in our class of residents. So currently we conduct these sessions every Sunday at 8 p.m. East African time. We do that through Google Meet, and we share the link in different WhatsApp groups. So I believe you are seeing some links even in the FITA group. So if you see someone disturbing your peace on a Sunday morning, that is me. And these are open to all clinicians and medical learners of all levels, medical students, residents. And the audience also participates actively, either by contributing or by typing their thoughts in the chats. And this is how we conduct the sessions, as I said earlier. So the presenter will start with the particulars and complaints, and then the discussant will share their thoughts on what they think is going on, and then we go to the next level, the history. The discussant again will share their thinking. Remember, they know nothing about the case, so they will go all the way until they commit to a diagnosis, and then finally the presenter will reveal the final diagnosis. So many times you find it's either they got the diagnosis right or they got it wrong, but what we are interested in is the process rather than the outcome. And finally, we end up with reflections where the discussant will do a cognitive autopsy on what they did right and what they did wrong, and what are the learning points for them. We saw the major difference in this kind of training, or what we do, compared to traditional teaching, for example. One is that it's based on real life problems, and it's real time. So it's you are like simulating a real patient encounter. You are sitting at a clinic, and then you encounter a problem. You try to solve it real time, and then you get immediate feedback on where you went right and where you went wrong. And it's also process focused, in that we are not very much interested in whether you get the diagnosis or not, but then you encounter a number of problems which will help you learn more. And the most important issue is integration. So when we read books, we learn in a disconnected manner. So you read arrhythmias, for example, and then next time you read how to interpret ECGs, are very disconnected. But here you encounter maybe tens of problems in one patient, and it becomes immediately clear with you on what you are good at and what you need to improve on. So if you encounter a problem of hypocalcemia and you do not have any differentials, then you know what your next reading should be based on. But another thing is, this is a very humbling experience, because as a physician, for example, if I discuss a case and encounter a number of things which I do not know about, it tells me on my shortfalls as a human, and on cultivating a mentality of lifelong learning. So far, in the past 2 years, we've discussed more than 100 cases, and this has grown from a passion project of 2 people to about 50 to 70 attendants every weekend, every Sunday. And so far we've uploaded about 81 videos on YouTube, and we share the links to those videos for records. And our YouTube channel, still very humble beginnings, but about 400 subscribers. We believe that tells us about the interest that people have when it comes to learning, and more than 8,000 YouTube views so far. And the WhatsApp group where we are sharing the link, there are about 477 members as of current. So looking ahead, we think that this is not everything, but then it supplements and complements the traditional reading that or learning that we are doing. And therefore we believe that if we scale this across Tanzania, it will solve a number of issues, like a shortage of clinical instructors, for example. It's like crowdsourcing of learning, and we've so far there's interest, for example, from colleagues in Obs and Gyne from KCMC. Some of them reached out and wanted to learn from us on what we've been doing, and they want to do the same thing when it comes to their specialty. But also we ask for cooperation and help from all of you, sharing the links with your junior colleagues that you have and other colleagues, so that it may not become just an issue of people from Dar es Salaam, because many of the attendants you find maybe they are from MUHAS and institutions based in Dar. And so if we scale this across the country, we believe that it will be another item in our arsenal of weapons to make sure that we prepare good clinicians. And maybe in the future we'll also see to make sure that we attain CPD accreditation, so that if you come there on a Sunday evening and sit and have fun for the 1 hour, you also get some CPDs for your continuous professional development. So at the bottom is the website, so the YouTube channel. But if you go directly to YouTube and Google AfroDx, you will find that, so you can share that with others in order to make sure that we learn together. So I would like to leave this quote for everyone to read on themselves. And thank you very much. About the case, I believe everyone will take their own time and think what was happening with that case, and maybe you can discuss in the group. Thank you very much.